I'm here with Ambassador Natalie Brown, the US Ambassador to Uganda, and I speak to her about the recent passing of the Anti-Homosexuality Act in Uganda. How does the passing of the Anti-Homosexuality Act in Uganda jeopardize potential HIV epidemic control in the country?
Uganda, and certainly in partnership with the United States and others, has made incredible strides towards to achieving epidemic control. And I think if you exclude one portion of the population, that undermines that completely. Key populations, these are people who are already vulnerable. Some of them are ostracized by their families or living in areas where they didn't grow up, or perhaps they don't have the support networks that they need. And if they are fearful of going to get treatment, if they are fearful that they disclose that they are members of the LGBTQIA plus community, and that's going to have an impact on their treatment, then it affects everyone, particularly if they are not undetectable and perhaps are not engaging in safe sexual practices. So it's really important that when we talk about epidemic control and ending HIV and AIDS by 2030, that we have an inclusive approach, and that means including key populations.
I also had a chance to speak about the impact of this law with Dr. Vasireddy, the country director for Uganda, who oversees all PEPFAR activities. So the anti-homosexuality law in Uganda, how has that affected service uptake?
Service uptake, because of the Anti-Homosexuality Act in Uganda, has suffered through the media discourse, through the debate in Parliament, and through the period it was introduced and discussed and signed. It took over a period of 6 months from the time it started being debated in the media to when it was signed. And during this time, we've noticed an inconsistent use of services, access to services by key population clients. And especially when you look at site-by-site data, the results have been quite inconsistent. Some sites have shown a serious drop in utilization of services, somehow gone up and down, and somehow remained steady. But overall, previously, before the law was passed, we used to see a steady utilization of services, but since the law has been introduced, it has been very inconsistent.
So if people are key populations, if they don't utilize services, what does PEPFAR do? How does PEPFAR reach them?
That's a great point. PEPFAR's philosophy has always been, if the clients are not going to the services go to the clients. So in that principle, we take the services to the clients, especially for eligible clients, like for example, a stable client. We do take ARVs, the ARV regimens, to home delivery, and for prevention services, we do home delivery of PrEP, so that clients who are afraid to go to a service delivery point or a hospital to access services, they can get the services delivered to their homes. And this is not new. This has been done in many countries, and in Uganda is one of the many countries that is adapting based on the climate.